Hi, Luke.
It might seem crazy what I'm about
It's
to say.
time for Cut to the Case. And Luke's here, so we're doing ultrasound. And Luke, you've got an interesting case. Tell us about it.
Yeah, so we've got an 85-year-old gent from a couple of weeks ago now who had a collapse at home. His son heard him fall in the next room and then went in there and he was unresponsive. So he did a couple of minutes of CPR and this guy kind of woke up essentially.
Right.
And then they've called the paramedics and they've arrived. He was quite tachycardic with a borderline blood pressure, but otherwise a bit confused, but otherwise talking.
So he's like a post-arrest. So he's a post-arrest case who's wheeled into your emergency department.
Yeah.
And brief CPR. So something catastrophic's happened, but he's come back to life. And here he is.
Yeah.
And I guess my thinking on this is, people like this, you feel a bit relieved, but actually you shouldn't be relieved because they're highly likely to arrest again unless you find the underlying cause.
That's right.
Enter the ultrasound. So what do you do? What's your ultrasound evaluation in someone post-arrest, Luke?
So particularly in these patients who are a bit hypertensive still, we sometimes can use the rush exam. So the rush exam is to look for, the cause of hypertension in the undifferentiated hypertensive patient.
So rush, that's already sounding difficult to me. So can we break down exactly what the rush exam is and how do you, what are the bits? And
yeah,
let's go through it.
Yeah, so some people, they use the mnemonic HIMAP. So H for heart, I for IVC, M for Morrison. So looking for free fluid in the abdomen. A for the abdominal aorta, and then P for pulmonary things. So looking for tension pneumothoraces, for example.
So take me through then. This guy's wheeled in, he's talking, he's tachycardic, he's still not so well. Where do you start?
Well, he had a little bit of chest pain / abdominal pain, but it was a bit vague. So nothing really to kind of clearly put our finger on. And he had this kind of unusual, bit tachycardic intermittently and a little bit bradycardic, but not profoundly bradycardic. Okay. So we thought maybe this is a cardiac issue and he's had
like
collapse.
a tachybrady.
Yeah, some kind of cardiogenic cause.
Yeah, and maybe the pain is angina.
Yeah, exactly.
Yeah. Okay. Yeah.
So obviously standard things, primary assessment and ECG. Which didn't really yield a whole lot.
So ECG is okay.
Yeah, he's a little bit tachycardic.
Not having a STEMI.
No, clearly no clear STEMI.
Yeah. So if it's me and I've got this guy, he's got abdominal pain. I'm going for the abdomen. I want to find out what's happened to his abdomen. But is that the HIMAP way to do it? Is that what I should be doing, or do you have a different approach?
Yeah, I mean, I generally do that as well. So, it's an undifferentiated hypertensive patient. In reality, you've got some other information usually. This guy had some chest pain and some abdominal pain. And so, start where the money is. And so either chest or abdomen and then work around the rest of it. Yeah. Okay. We had a little bit of time as well. He was borderline hypertensive, but, mentating okay.
All right. So where'd you go first?
So we started with the chest, actually started looking at the heart, given that he had this kind of arrhythmia as well, and so I had a look to see if there's a pericardial effusion, if there's any obvious kind of regional wall abnormality or LV down or anything like that.
Right, that's getting hard. I'd be thinking, is his heart empty or is it full? Contracting. So is he hypovolemic shock? Or is his heart not pumping? So is that the way to think it?
Yeah, I like to think of it, particularly cardiac exams, as a yes or no answer. So is there pericardial effusion, yes or not? Is the heart pumping, yes or not? Or is there signs of increased right heart pressures, like with a PE, yes or no? And then while you're there, we'll have a look at the IVC, which will help to kind of guide that as well.
And this is what it looked like.
Yeah, so you can see he doesn't have a pericardial effusion and he's a bit hyperdynamic as well.
So hyperdynamic, beating hard, undervolumed.
Yeah, so we just rotate the probe, have a look at his IVC while we're there, and he looks like his IVC is collapsing, so probably undervolumed.
The volume, so it's probably dehydrated, bleeding somewhere.
Could be.
Maybe we should have started with the abdo like I suggested, because I reckon that's where the money is. Okay, but that's useful. So then what do you do from there?
So in terms of abdo, we can look for free fluid in the abdomen, which is obviously similar to doing an EFAST, at least the right and left upper quadrants, or we can look at the abdominal aorta. So we look at both of them ideally, but depending on where you think the money is where you go first.
And I suppose a AAA is, one of the things. Did he have back pain, or is he?
He did have some pain. So on kind of further questioning, as he was becoming a bit more, clear in his sensorium, he was more a bit epigastric pain going through the back.
Okay, all right. So AAA is definitely in there, and all the while he's sort of improving.
Yeah, he's kind of
Yeah.
he's not getting worse, but he's about the same essentially. Yeah,
And like clinically, abdo, anything to find?
not really. Like he was maybe a little bit tender in the
Not an
the
obvious
abdo.
triple A.
No,
No, and
no.
not peritonealism, not a surgical abdo.
No,
Didn't
exactly.
seem to be bleeding there. Well, this is tough.
Yeah, he was pretty relaxed, to be honest. But considering he's an 85-year-old guy,
Oh,
just had CPR for 2 minutes,
sure.
he was very chill.
Okay. So let's cut to the case then. So we get onto the aorta. Take me through what you're seeing. Like,
So big aortic aneurysm. You can see
yeah.
that.
And can you say where and when and ruptured or not?
Yeah,
Or
so we have a look. We can see we scan up and down the aorta. It looks like it's infrarenal. There's maybe some intramural kind of thrombus in there as well, which is sometimes you can see with associated rupture. There's no obvious dissection flaps or anything that we could see. And then we then had a look to see if there's any free fluid at the abdomen.
before you get to that, I always wonder, how do you, people talk about this size. How do you measure the size of the AAA? Is it from the outer wall, inner wall,
Yeah.
plaque? I mean, this is something that confuses people.
Yeah.
Take us through.
So you go outer wall, and you want to assess in a couple of different dimensions. So AP, and then kind of medial to laterally, and you can sometimes look in both transverse and longitudinally. Essentially, if you find one measurement that is concerning, then that's enough.
Yeah. Okay. So you err on you err on the side of caution. One measurement too big. That's a problem.
Yeah.
Okay.
And I think of it as is undifferentiated hypotension with signs suggestive of a AAA. It's ruptured until proven otherwise, even if I see any of those other signs.
So I'll tell you what I'm doing at this point. I'm going to CT. I'm calling our vascular surgeons.
Yeah.
Is that kind of what happened? Or
simultaneously.
Yeah. Maybe
CT.
anesthetics. Get them involved.
Yeah.
And just again, ruptured or not ruptured, or don't know.
Well, I mean, don't know. He had no obvious free fluid in his abdomen, but then often these will bleed retroperitoneally.
Because that's the thing, right? It's going to be retroperitoneal. There's no way of saying.
Sometimes you can get, if there's enough fluid there, you might get some abnormality around the kidney. You might get some distortion of kind of the bladder if there's huge volume with kind of extrinsic compression.
But all those normal things we do with the fast ultrasound are not actually going to be helpful, because Morrison's pouch is intraperitoneal, so it's retroperitoneal.
Exactly,
so this is the problem. Yeah, and you can't see a leak or something, like, no,
not obviously,
Doppler,
but look, you could try that, but I mean, again, it's for me, is it there, yes or no, and then that's the decision to go to CT or go to the theater.
All right. So what? That's the end of the story. He goes to CT, and that's fine. Is that what happened?
Not quite.
Or is there more? Tell me more. What's the conclusion?
So he goes to CT. We confirm he does have a big infrarenal AAA.
Yeah, right.
It has ruptured, but there's no active kind of extravasation indicating he's got ongoing bleeding at the time.
Yeah.
But he had a big retroperitoneal hematoma around his kidney. So spoke to vascular. They're looking at the scans, alerted anesthetics, and then heading back to the cubicle and getting him ready, essentially, to go and have a repair of some kind when vascular decide what they're going to do.
Job done.
Feels like that, yeah.
Feels like that. But there's more.
Yes.
So tell me what happened.
So it's dinner time. So I thought he's heading in the right direction. Vascular have agreed. They're going to do an endovascular repair.
Yep.
Anesthetics are at the bedside. They're about to wheeling up. So I thought, good. He's basically out of the door.
Yep.
I'll go and get some dinner.
Yep.
And then the buzzer goes off. So we rush back in, and he's having CPR.
Oh my God. So he's actually rearrested.
He's rearrested. Yeah.
So I mean, again, this is the thing, isn't it? Someone who's arrested, is post-arrest, who comes to you, they're highly likely to arrest again.
Correct, yeah.
You've found the pathology, you've lined him up for the definitive treatment, he's rearrested.
Yeah.
So did he make it, or what are we talking here?
So he had CPR for about 10 minutes or so. He had some fluid resuscitation during that time. There was some discussions at the end of the bed on each rhythm check. He had no shockable rhythm. He had no palpable carotid pulse. We discussed with vascular and anesthetics about whether or not he would go for an open repair.
Yes.
And they felt that given that he was 85 and had rearrested, the chance of
because the mortality of that is
super high.
Yeah. We're talking what, 80%? Something like that. It's really high. So gee, that's awful. Yeah.
So started family discussions.
Yep.
Ceased CPR.
Yep.
With a plan to move to kind of, getting the family in to spend some time with him.
Palliation. Yeah.
And then his heart rate started to come back and then increase. And then he had a blood pressure that was still cycling in the background.
Yeah,
and
like one of those
cycled to
blood
be-
pressures that probably will stay low, you mean?
Yes.
Yeah,
Yeah. So it
yeah.
came back as I think 65 systolic,
Yeah, yeah.
and then tried to reassess him, and
Mm.
he felt a little bit warm still, and then he
Mm.
started to have a radial pulse, and then he
Mm.
started to wake up.
Oh my God. So
Mm.
he actually pulled through.
Yeah, he had a bit more fluid at that point, and then there was rediscussion, and probably what happened is he had a second big bleed, had a lot of retroperitoneal stretch from the bleed, and a big kind of vagal response essentially.
Yeah.
But he had no output, no central output
Wow.
for at least 10 minutes.
And so it's a happy story. So he actually pulled through, went
Yeah.
to theatre, and did okay.
Did okay. He went.
Yeah.
He actually had a endovascular repair done under local.
Wow.
So
Gee.
they didn't want to tube in because of his significant instability.
Okay. Yeah.
And he did really well.
Well, that's amazing. So I guess amazing case, Luke. And I think again, there's a lot in it. There's the whole thing about post arrest,
Yep.
doing the ultrasound. There's the rush protocol.
Mhm.
Sounds like you're starting with the heart. I'm starting with the abdo.
Yeah.
I think if I started with the abdo, I would have had the diagnosis quicker.
Yeah.
However, I probably would have found a AAA and I would have been stuck with, well, is it leaking or not? You
Yeah.
add the cardiac part to it. He's
Mm.
undervolumed. He's collapsed.
Yeah.
This plus that equals he's probably bled. And
Yeah.
then he's rebled.
Yeah.
And the definitive treatments or the definitive management is always going to be further imaging. He's going to need a CT, and he'll need someone who can fix that. And in our shop, it's going to be vascular surgery.
Correct. Yeah.
And thankfully for him, it was the optimal treatment, which is endovascular
Yeah.
stenting, which is a lot safer.
Yeah.
Great case, Luke. Lots to think about. And
seem
all right,
crazy
thanks.
what I'm about to
That's enough from us.
say.
See you next time.